The patient I'll be reviewing today is a 69-year-old Caucasian female with a psychiatric history of major depressive disorder, generalized anxiety disorder, post-traumatic stress disorder, and alcohol dependence. The MDD, GAD, and PTSD, she states, are related to a recent divorce with an abusive husband. In regard to her alcohol dependence, she's tried to stop drinking, quote, several times in the past and has been unsuccessful. She's had 3 previous hospital admissions for alcohol withdrawal, at Arrowhead 2 times and UTMC 1 other time. Current home medications include Lexapro 20 for anxiety and depression, Minipress 1 at bedtime for nightmares related to PTSD, and Klonopin 1 as needed for breakthrough anxiety. She's active in outpatient therapy for mental health weekly. She likes her therapist and feels that it's helpful. Patient lives at home in an apartment in Elmore, Ohio. Patient states she has support from friends and adult children. Patient denies legal issues, and she denies trouble obtaining food, medication, or transportation. Her medical history includes Hashimoto's disease, for which she takes 137 milligrams of levothyroxine. She's had gastric bypass surgery and 2 rotator cuff surgeries, for which she takes Aleve for breakthrough shoulder pain. She presents to the UTMC Recovery Services Unit with alcohol dependence with active withdrawal. She drinks 1 to 2 pints of rum daily, and she says she's been drinking that way for about the last 25 years or so. Her last drink was just prior to her admission the night before, approximately 8:30 at night. The assessment was done at approximately 9 a.m. Her current withdrawal symptoms include anxiety above her baseline, rated 7 out of 10, headache, feeling shaky, and objectively, we observed mild tremors in her arms when she extended them. And also objectively, there were beads of sweat that were noticed on her forehead, and her face was flushed. The CWA score as of 9 a.m. was 10. For that, she was given 1 milligram of Ativan, 650 milligrams of Tylenol, 0.1 milligrams of clonidine, and 25 milligrams of hydroxyzine per the unit protocol. And the floor nurses, after they pass meds on that unit, reassess with a follow-up CWA and vitals every hour for as long as they're giving medications. In regard to her plan, we're going to continue to monitor her withdrawal symptoms, utilize the PRN medications in the unit protocol as needed, and follow up with a second provider assessment in the early afternoon. For that assessment, that yielded fairly similar results to the morning assessment, with the exception that she started to feel some mild nausea but hadn't vomited. CWA score at that time was 12, and she was medicated with 2 milligrams of Ativan, 300 milligrams of gabapentin, 0.1 milligrams of clonidine, 25 milligrams of hydroxyzine, and 4 milligrams of Zofran. Let's see, getting back to the plan, we plan to find her some referrals for an IOP program. She's failed several times outpatient and feels that going straight from an inpatient setting directly to an outpatient setting without something in the middle is just not going to yield success for her. So we're looking for IOP programs near her home, and her projected discharge is approximately 4 days, depending on the patient's condition. Thanks.